All right, let's jump right in. Today, we're breaking down alcoholic liver disease for clinical practice. We're going to move fast from the classic lab findings you'll see in the ER all the way to the evidence-based treatments that can really change things for your patient. Let's get to it.
So here's how we're going to tackle this, and we're going to do it just like a real clinical encounter. First, we have to recognize the disease. Then we'll assess just how sick the patient is. From there, we'll talk first-line treatment, dig into the evidence from a huge clinical trial, and wrap up with what really matters, long-term management.
Okay, so picture this. A patient comes into the emergency department. You suspect heavy alcohol use is taking a toll on their liver. What are the signs? What are those red flags in their story and in their labs that should make you immediately think, this could be alcoholic hepatitis? Well, it turns out alcoholic hepatitis has a pretty distinct laboratory fingerprint. You'll see a high white blood cell count, but here's the classic clue, the one that shows up on board exams for a reason. It's that AST to ALT ratio being greater than 2. Just remember, AST is the star of the show here. The liver enzymes, they're elevated, but usually in the hundreds, not the thousands. You add a rising bilirubin and a creatinine that's starting to climb, and, well, the diagnosis becomes very, very likely. So once you recognize that pattern, and alcoholic hepatitis is at the top of your list, the very next step is to figure out the severity. And look, this isn't just for academic points. This is a critical fork in the road. It's what determines if your patient needs supportive care or if they need specific life-saving medical therapy right now.
So let's think about that patient right in front of you. They're jaundiced, their bilirubin is going up, and their blood is getting thinner, right? That's your rising INR. So how do you take all that whole clinical picture, and turn it into a hard number, a score that actually predicts their risk of dying and tells you exactly what to do next?
Well, the answer is a tool that's been around for a long time, Madre's discriminant function, or just the DF score. This isn't some new fancy thing. It's been validated for decades as a super reliable way to stratify risk in these patients. And, most importantly, it helps us pinpoint who is most likely to benefit from corticosteroid therapy.
And the beauty of the formula is its simplicity. I mean, in a busy hospital, that's a huge plus. It just uses 2 lab values that you're going to get anyway, the prothrombin time, or PT, and the total serum bilirubin. That's it.
So here it is, the number that matters, 32. This is the magic number, the threshold. A DF score greater than 32 tells you, plain and simple, this patient has severe alcoholic hepatitis. They have a high short-term mortality risk. This is our trigger to go beyond just supportive care and to start specific medical therapy. Okay, we have our number, we have our threshold, so now what do we do with it? Let's build out the treatment plan, using that DF score to map out a clear, evidence-based path for these really sick patients. This gives us a super clear, actionable pathway. Step 1, you calculate that DF score. If, and only if, it's over 32, you start corticosteroids. But, and this is a big but, don't forget the fundamentals. Aggressive nutritional support and counseling for complete alcohol abstinence, those are absolutely essential for every single one of these patients, no matter what their score is. And for severe disease, the evidence is crystal clear on this. The standard of care is a course of prednisolone. We're talking 40 milligrams a day for 4 solid weeks, and then you do a gradual taper. This isn't one of those situations with a bunch of different options. For DF over 32, steroids are the go-to. But why corticosteroids? I mean, where does this recommendation actually come from? And what about other treatments? To really get it, we have to look at the landmark STOPA trial. This is the study that gave us the high-quality data that shapes everything we do today. You see, the STOPA trial was designed to settle the debate once and for all. It has 2 really simple but crucial questions. 1, does prednisolone actually save lives? And 2, what about this other drug, pentoxifilion, that some smaller studies had suggested might help? The trial put them both head-to-head against a placebo. So let's just focus on the key results here. Look at prednisolone and the 28-day mortality. Mortality dropped from 18% down to 14%. That's a 4% absolute risk reduction. Now look at pentoxifilion. No difference at all. And this is the critical part. For both drugs, any hint of a benefit completely vanished by 90 days and 1 year. So what's the bottom line here? What are the big takeaways? Well, number 1, there was a trend toward improved survival at 28 days with prednisolone. That p-value of 0.06 was so close to being statistically significant, but it didn't quite get there. Number 2, the trial was a slam dunk for pentoxifillin. It offers zero benefit. And maybe the most important lesson of all, neither drug made any difference in long-term survival at 90 days or 1 year. And that last point from the trial really sets the stage for our final topic. The data is telling us that treating the acute fire with steroids, it's just a short-term fix. It's like a bridge, but it's not the destination. Real long-term survival depends entirely on what happens after that patient walks out of the hospital.
And these 3 things, they are the absolute foundation for a patient's long-term prognosis. The single most important factor, and I cannot say this enough, is achieving and maintaining complete abstinence from alcohol. It's everything. Right alongside that, these patients are often incredibly malnourished, so aggressive nutritional support is key. And finally, for those whose livers are too far gone, a timely evaluation for a liver transplant can be a lifesaver.
And that right there is the key message to leave you with. Look, our acute treatments, like giving steroids to a patient with a high DF score, they can absolutely be life-saving. They can get a patient through that initial violent storm of inflammation. But the war isn't won in the hospital. Their long-term prognosis, their shot at a healthy life, it all hinges on one thing: their ability to stop drinking for good. That is by far our most powerful therapy.